From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello and welcome to this JAMA Author Interviews podcast. I'm your host, Dr. Preeti Malani, JAMA Deputy Editor. I'm joined by Dr. Susan Huang, who is the Chancellor's Professor of Infectious Diseases and the Medical Director of Epidemiology and Infection Prevention at the University of California, Irvine. Dr. Huang is the senior author on an article titled Reducing Hospitalizations and Multidrug-Resistant Organisms, Regional Decolonization in Hospitals and Nursing Homes, which was published in JAMA on April 1st, 2024. Susan, thank you for making time to join this conversation.
Pleasure to be here. Thank you.
In terms of infectious disease issues, our collective attention has really been focused for the past 4 years on COVID. But the more day-to-day concerns around antimicrobial resistance have not gone away, and in fact remain one of the biggest threats to human health globally. Compared with antimicrobial susceptible organisms, infections due to multidrug-resistant organisms, or MDROs, are more difficult to treat and are associated with increased morbidity, mortality, length of hospitalization, and healthcare costs. With limited therapeutic options, there's an urgent need to prevent the spread of MDROs and decrease the number of associated infections and hospitalizations. Although MDRO rates are high in hospitals, the prevalence of these organisms is truly staggering in long-term care, both nursing homes and long-term acute care hospitals, or LTACs. This high prevalence fuels spread as patients colonized with MDROs are often shared among nursing homes, LTACs, and hospitals. Which brings us to your study called SHIELD OC, which involved coordinated action across regional healthcare facilities to reduce MDRO burden and interrupt transmission. So with that introduction, can you please briefly tell us about this work? How did this effort emerge? What was involved and what happened?
Absolutely. Well, the story is that the Centers for Disease Control and Prevention, the CDC, released a special call for regional interventions to control antibiotic-resistant organisms. And the goal was to first use simulation modeling to test a range of interventions, and then to implement the most effective intervention in real life. This project was that real-life intervention. And we invited hospitals and nursing homes and LTACs from Orange counties, which is why it's called SHIELD OC, that shared a high number of patients with one another to join this collaborative decolonization project. And 35 of them agreed. So the idea behind decolonization is to reduce the amount of bacteria on the body's surface to prevent infections during high-risk moments. And patients in healthcare facilities, they're at risk for infections that are largely due to our body's own bacteria. So we had staff in the long-term care facilities, the nursing homes and the LTACs, swap out regular soap for chlorhexidine antiseptic soap for all bathing and showering. And they used povidone iodine swabs in the nose Monday through Friday every other week. And hospitals used chlorhexidine and nasal ointments on patients in contact precautions, which includes those who are known to have resistant organisms. And what we found is that this combined regional partnership, this decolonization intervention, did several things. First, it reduced resistant organisms in hospitals by 14%, nursing homes by 22%, and LTACs by 33%. And second, it reduced pathogens in clinical cultures by similar amounts. And finally, we were able to show that decolonization protected nursing home residents from serious infections. Hospitalizations due to infections dropped by 27%, and the associated costs and deaths dropped by a similar amount.
So you mentioned costs dropping. Do you have numbers in terms of the cost of the intervention itself?
Yes, soap, fortunately, is quite inexpensive. It is more than regular soap, but we're really talking about probably about $1 more a bath, much less than that for the extra liquid for a shower. The nasal iodophor that you use, the swabs in the nose, those can be obtained for several cents. And so it's cheap, but it's not free. And when you add it up to apply it to everybody, because it's a universal process where you want to keep these organisms at bay and keep the whole nursing home and hospital and LTAC protected, it can rise to the point where I do think it should be incentivized by insurers that are saving the very high costs of preventing a hospitalization.
So when you look at the global costs, and again, the cost of care in the hospital and even in LTACs and nursing homes is exorbitant, the cost of this intervention comparatively was quite small, manageable, I would say.
and enough to actually see a return on investment at the local level in the nursing homes and the LTACs and the hospitals, as well as, of course, at the payer level and definitely at the societal level.
Susan, did anything about the study or the results surprise you?
Yes, I think two things. First, it was really eye-opening to see how many nursing home residents actually are colonized with a clinically significant antibiotic-resistant organism. That number is 65%, meaning that the majority of people in a nursing home have one of these resistant organisms. And even more striking, that number is 80% in the LTAC. So being resistance-free is a rare event, and that's really unacceptable. I think it's a potent reminder that protecting these patients and residents in these settings, it really needs to be a priority in our fight against antibiotic resistance. And I'd say the second thing is much more personal. As a physician that is dedicated to preventing infections, we always say that the work that we do saves lives. And while we deeply believe that that's true, this is the first time that one of our projects has been large enough and focused on a high enough risk population that the data actually show us that deaths were prevented by the decolonization intervention. And I would say personally, that's an incredibly special moment.
As a fellow infectious disease physician, when we're doing our job well, no one necessarily notices. And so it's nice to be able to put numbers on that.
Absolutely.
So you and your colleagues were able to achieve impressive results in Orange County, California, preventing not only infections, but also reducing hospitalizations and saving money. How do you think these results might inform prevention efforts in other parts of the U.S.? And what barriers do you think people might face if they were to try a similar collaborative effort?
I believe that this intervention, swapping out soap for chlorhexidine and using a nasal ointment to reduce skin and nose bacteria, I believe it has real promise for adoption in healthcare settings across the U.S. These are over-the-counter products. They've been used in healthcare for over 60 years. They're incredibly safe. I'll say that this is the most studied soap known to humankind at this point. And so it's a very adoptable intervention in the normal routine daily care of patients and residents where they're supposed to be bathed and showered, and to switch out the products that you use could be seen as fairly exchangeable for the benefit that it yields. But as you mentioned, nursing homes and LTACs, they are lower resourced settings. Even though the soap and the nasal iodophor is definitely not expensive, it does increase the cost to a local facility that's trying their best to do cost containment. And so I do think that the barrier of the extra cost for hospitalizations and nursing homes could really be benefited greatly by insurers who incentivize this intervention by covering the product costs and supporting the cost of the extra training. I'll say that we have a real world experience with this in Orange County. Orange County Medicaid saw a large reduction in their outlay of costs from this intervention over the course that it was being performed. And currently, CenCal, or Central California Medicaid, is now adopting an incentivized portfolio where they're actually covering the costs for nursing homes that adopted in that region and also providing nurses and staff to really encourage it to be done properly. And maybe that's the last barrier that I'll talk about, is to caution that this isn't plug and play. Staff aren't naturally comfortable bathing patients with wounds or rashes and devices. And if you don't teach them that these breaks in the skin are the most important areas to clean to prevent infection, they'll avoid cleaning these areas, and they'll clean all the intact skin and leave all these areas where germs can dive into the body and cause infections. So it has to be that we couple this intervention with education and training, and definitely to assess the thoroughness of bathing and showering. Otherwise, none of these benefits that we've talked about will be seen. But we have things to help with that in the supplement of this paper and online, and some of the links that we provide in the manuscript. There are free educational materials, training modules, and videos online that can really help with adoption in each of these settings.
Dr. Susan Huang, thanks for joining us. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.